Good afternoon. My name is Fran Brotherhood, and I work with Interim Healthcare Gift of Hospice, and Keith invited me here today to talk to you a little bit about palliative care and other care options for you as your needs may become greater for outside support. And that's what I'm here to do. And I don't know if there's a way for you to ask me questions or not, but hopefully if there is, we'll figure out a way to do that. In the meantime, I'll just go ahead and tell you what I have to tell you. So first of all, who am I we've covered, and the why I'm here we've covered. And what we're going to discuss is a couple of different care options that will become available to you when you begin to need some outside support for your care and your family just don't have the resources to do what needs to be done for you. There are a lot of myths surrounding different kinds of care, and I hope today that I can give you some simple answers to show you what the different options are. So palliative care means basically comfort care, and there's lots of different kinds of palliative care. Palliative care is not necessarily hospice care. People confuse the terms palliative and hospice, and a little later on I'll talk to you about what the differences are. But basically the goals of palliative care are to provide patient and family empowered care, preserving dignity and providing comfort. So not all care is palliative, but all hospice care is palliative. So what that means is you can have people that have conditions from which they are expected to recover, but they elect to have palliative care rather than curative care. In the hospice situation, most patients have a diagnosis of 6 months or less and have elected for palliative care. I say most patients because, in fact, as you're going to hear in this presentation, you can actually be in the hospice program for a lot longer than 6 months. We have patients in our program, some of them now have been with us for about 2 years. And I'm sure you've probably heard stories of other families that have used hospice programs for a longer period of time. I can talk to you a little bit later about how that happens. So there's 4 levels of care in the program. One is routine home care, and this is care where you would be in your home. Your family and friends would be caring for you, and you would have access to the hospice team who would come to visit you as often as you and they deem necessary. You're the people, the family is the one that chooses how and when the care is going to happen and who's going to be given it. It's all directed by the family and the patient. If you, by any chance, are living in a skilled nursing facility or other sort of facility, hospice care can be provided by hospice, and palliative care can be provided by hospice and palliative organizations in that facility as well. So basically the care it's care that's given wherever it is that the patient or the family, well, the patient in fact, calls home. So if you're in a facility, that's where we would care for you. If you're in your home, that's where we would care for you. If you were in an RCFE, or what used to be called a board care, which is a smaller care home, we would care for you there as well. It's the same people, the same team that would care for you no matter where you were living. The second level of care is what's called crisis care, and crisis care means that we would have someone in your home, or there would be a team member in your home most of the time to help try and take care of whatever the crisis is. Usually it's a pain crisis that we're dealing with, and when we get that organized and set up, then the staff would leave. In the olden days, in hospice programs, Medicare used to pay for private bedside care. That is no longer true. The hospice benefit now is a team approach, and the team members come and go as the family directs and wishes, and as the patient directs and wishes as well. Inpatient respite care, if it's determined by the team and by the family that the family needs some time off, that they're getting exhausted by caregiving, we will go ahead and provide the opportunity for the patient to be in a facility where they can get the care for up to 5 days. And it can happen multiple times. You don't just have one shot at it. You can have 5 days every so often where the patient can be in a facility and the family can have some time off from caregiving. General inpatient care is a situation where the patient's symptoms cannot be controlled or managed at home. And in that situation, the patient is admitted to the hospital, but is still under the care of the hospice team. So they're actually housed in the hospital, and the facilities of the hospital are being used to care for the patient, but the hospice team is coming in to look after them there. And again, that's usually a short-term situation for a day or two at a time. So I'm not sure how well you can see this slide. I wanted just to talk to you a little bit about the care team that's responsible for caring for a patient who's in the palliative care system. basically there's four things that we're looking after: the physical needs, spiritual needs, the emotional needs, and the social needs. And you can see that in this graphic they're given equal weight. There's not one of those four segments that's any important than any of the others, and there are team members on the team that are equipped to help you with all of those things. A key member of the team is the patient's attending physician. So one of two people can be that attending physician. It can either be the medical director of the hospice, or it can be your current attending physician. If you choose to have your physician care for you, then that can happen. But I will tell you that very often physicians are more happy than not to sign the care over to the hospice physician, medical director, simply because that's their job and that's what they focus on. And most providers of healthcare are not equipped to work quite as well with people at that stage of life as people that choose that as their profession. I see Keith has a question.
Are we talking about their primary care physician or the neurologist?
No, it would not be the neurologist. It would be their primary care physician. Thank you. So the program medical director, the responsibilities of that person is to lead the interdisciplinary team in development of the plan of care and provides consultation to other physicians regarding the patient's care. So our doctor, the doctor in charge, would consult with whoever the patient's physician is and clarify any things that needed to be clarified in terms of current medication regimens, or if they were going to make changes. More often than not, as I say, those physicians are happy just to turn the care over to the management of our team. The RN case manager is a key person on the team. Each family is assigned an RN case manager, and that person is responsible for developing the care plans and working with other team members to schedule visits. So basically they do the initial assessments, they develop the plan of care, they coordinate all the visits between the people like the aides and the social workers and the chaplains and the other staff. And they are also responsible for ensuring symptom control and pain management. They also provide the family and the patient a lot of training. There's a lot of what we do is train family members to care for the patients the best way. Obviously, bearing safety in mind. Safety is a big issue with us, as I'm sure it is for all of you. A lot of our training revolves around safety and also different use of different drugs and that sort of thing as well. The RN case manager is the person that acts as a liaison with the doctor. So that while there are lots of team members coming in and out, and the team meets regularly as a team, the person that's the RN case manager that deals directly with the doctor and in terms of coordinating that level of care. Social worker, I see my slide's a little screwy there. The social worker got up in the picture. The social worker's job is basically to assess the patient and family emotional, social, spiritual, and financial needs, and develop a plan of care to meet these identified needs. The social workers actually act as a go-between in the community. They have the ability to find outside resources that are needed, anything that our team can't do or that needs a specialty referral. The social worker is the person that would take care of that. They also take care of more mundane things. They help with mortuary arrangements. They help with any other care situations that the family might need. Again, as I say, that aren't provided by our organization. They also provide psychosocial counseling to the patients and families as they need it. The chaplains are responsible for the spiritual needs of the family, and I know in the earlier slide it said that the social workers took care of the spiritual needs. In fact, in our organizations, it's more the chaplains that take care of spiritual needs and would defer to the chaplains if that was appropriate. Not every family wants to be visited by a chaplain. Most do. Some decline the chaplain visits. In that case, a social worker would take care of those needs as well. The chaplains are responsible for obvious things like caring for spiritual needs, any sort of spiritual or scriptural things that the family wants, and also provides direct counseling. And then afterwards, the bereavement chaplain supports the family after the loss for 13 months, and that's part of the Medicare benefit. So once the patient dies, the family is then turned over to the bereavement team, and there's a bunch of different activities that are carried on by that team, including gender-specific grief support groups in our organization. We do mailings, we have an annual memorial service, and we do individual counseling as needed for family members after the loss. The home health aide, these are people that provide the most direct care to the patients. They have an intimate connection with the family. They're very often the people that know most of what's going on. They're in the homes much more than any of the other team members and become very often much closer with the families and others. And from my perspective, they are among the hardest working members of the team. Question?
We had trouble finding parking.
We're webcasting.
I think
We
all
had
do.
trouble finding parking.
I
Sorry,
know.
we're a few minutes late.
No, don't worry.
Could you please introduce yourself and say what company you work for?
Yes, absolutely.
Sorry,
No, no
missed that.
worries. My name is Fran Brotherhood, and I am actually a chaplain, and I actually run a bereavement program. But I'm acting today as spokesperson for Interim Healthcare Gift of Hospice. And we are
What hospice? I'm sorry.
It's Interim Healthcare. We are one of the smaller hospice programs in the county. We do have a large number of ALS patients in our population. And it's part of the work. We enjoy doing it, and in all humility, we think we do it pretty well.
Thank you.
You're welcome.
So since we went down that path,
Yes.
how do people find you? Do they find you through referral? Or are they using you for palliative care? Or how does that work?
That's a great question. When a family, and I'm going to get to this later on in the presentation, some more details about that, but basically the hospice benefit, if you're talking about hospice and palliative care, you ladies missed this, the two terms are very often confused. Palliative care just means comfort care. So all hospice care is palliative care, but there is palliative care that happens outside the hospice situation. So that might be somebody that just elects to have comfort care and not curative care, but is not necessarily hospice appropriate. So the hospice benefit, if you are looking for a hospice and you talk to a medical professional or a social worker, the Medicare law says that you have to be given the name of 3 hospices, and then you as a family or the family and the patient together would decide who they wish to go with. And they can do their own research. There's a lot online. There's a really good grading system online. You can look up the name of the 3 hospices that you're given and see how many stars they have or something equally sophisticated as that, but there's a lot of places you can go. So by law, the families have to be given 3 names, and they make the choice between those 3 names. I'm going to say this later on, but I'll say it now too, because it's one of the biggest myths of hospice. You do not need a medical doctor referral to become part of a hospice program. Hospice is self-referral. So if you know somebody or of somebody that you think would benefit from hospice care, find a hospice that you like or that you want to talk to, or find 3 that you want to talk to. Call them up, have them come in and talk to them and decide if one of those programs will work for you, okay? You do not need any referral from a doctor at all. The responsibility to decide whether or not a patient is appropriate for hospital care, the responsibility lies with the agency, not with the family. So if we admit people into our agency that are inappropriate, they find us very quickly. So we're very careful who we take, and different hospitals have different guidelines. Some of the bigger corporate hospices are a bit tougher on who they'll take because, you know, it's a money game for them. Some of the smaller hospices, and we're one of those, we spend pretty well almost everything that we get apart from our operating expenses back on patients, and have a lot of ancillary programs because of that that you don't get in some of the bigger programs. I don't want to digress too much. Another question.
Yeah, my question is, what criteria do you use to determine that, and where you make that decision, and it's not the doctor making the referral, but it's you discussing it with interim or whomever?
Right. The patient has to have a diagnosis of a disease or condition that without medical care would likely lead to death within 6 months. But nobody can play God and say that's true. And as I mentioned before, these ladies came in. I don't know if you were here or not. There is, you can be in hospice for multi 90-day periods. So you're admitted for a 90-day period. At the end of 90 days, you're recertified that you're still hospice appropriate, and that determination is made by the team and the medical doctor of the hospice. And those recertifications can go on for as long as it takes. All the patient has to be doing has to be demonstrated that they're declining during that time. So a lot of the work that we're doing is making sure that there is a measurable decline in the patient's well-being. But I said we have a couple of people who have been with us right now for 2 years. Beyond 2 years, Medicare doesn't really like that. And we never expect to have somebody there for 2 years. But very often, when people come into hospice and are taken off their drugs, because one of the things a lot of them want to do is to get rid of all the drugs they're on, they actually improve and rally. Most hospice patients come in with 22 medications. And one of the first things we do is go over that list. The doctor goes over that list with them and with their family physician if it's appropriate, or otherwise they make a decision which ones are no longer appropriate. Very often people who are dying don't need beta blockers anymore, and you take somebody off a beta blocker and they feel like $1 million. So very often we see patients rally.
Did you say 22?
Mm-hmm. That's average.
I'm concerned about 9.
I think what happens is, from my observation, is that a lot of times the medicines just get added and never taken away. So the patient ends up with a long stack of stuff they're not using.
So at that point, do you communicate that feeling to them, and then?
For
Yeah.
the webcast, you want to repeat your question?
I'll give you a precise example of that.
Okay.
If we have an end-stage cardiac patient, so this is someone that's probably had cardiac disease for many years and is at the point where they're nearing the end of their life, our doctor will discuss with them the option of stopping their cardiac medicines altogether, which sometimes has the effect of making them feel better. They're not doing them any good anymore. They're already dying. So to take them off, it makes them feel more comfortable and means that they don't have to be burdened by taking 22 medicines a day. That's a very common one. A very common one. Any more questions?
Yeah, so while we're here on this whole pharmacy,
Yeah.
what do you recommend? I mean, if you're concerned about 9 or 22 and you're having discussion with hospice,
Yeah.
or even before that, who's your best friend? Is it your pharmacist? Should they be aware of all 22? Because sometimes people go to different pharmacies.
Yeah, no, they should. Your doctor really should know. That's who you should be talking to about it. And I don't know. It's not my field of expertise, but I don't think I personally ever met a doctor that is willing to just take people off medicine for the sake of it. Which is rather the unique position that a hospice physician has. They can say, "Listen, this really isn't doing you any good anymore." Mm-hmm. Another case would be people that are taking diabetic medicine that are really close towards the end of their life. There's no need to continue with that,
Right. Okay. So what we would say from the chapter on medication is people don't, in our experience, utilize their pharmacist, who's a vast store of knowledge for different formulas. If you're trying to get a drug through a feeding tube as opposed to... But you have to have a session or schedule with them. Hey, here's the 22 my loved one's taking. Can we sit down and talk about these?
Right.
And that can often be very helpful. And then you can have questions to go back to your primary care.
Yes, I think if a patient were not involved with if you were involved with an organization like ours, you would be having that conversation on the first visit with the hospice doctor. That conversation would be had. If the patient were not in a program like this, or not in, I can't speak for all other programs, but not in our program, then the pharmacy would be a good place to start. I can't imagine what might happen after that, but it would be a great place to start. Okay. Anything else?
No, thank you. We'll let you get back to your program.
Fire on here. So on the Medicare hospice benefit, 5% of patient care has to be given by volunteers. And the reason for that is that when the hospice program started, they were all volunteer. And they've made sure that presence stays alive. So we have I think right now in our organization we have 43 employees and we have 38 volunteers. And they are busy all the time. And volunteers don't do any medical care or bedside care. They're basically doing just visiting, maybe reading with the patients, maybe doing light housework, maybe just sitting with the patient while the caregiver goes outside doing respite care, that kind of thing. And we also have volunteers that work in our office that do filing and that kind of thing as well. And volunteers are all trained the same way. They go through the same orientation program. They go through the same process as an employee does. The only thing is, at the end of it all, they just don't get paid. And I'm always surprised how many people there are that are coming forward. Many of them are young people that are on a medical track in university and want access to being in this kind of environment. So the other people then on the team we do a lot of ancillary programs. I can't guarantee that you get all of these in another hospice, but these things are all available to our families. Bereavement counselor, I talked a little bit about the bereavement program. We have speech language pathologist, physical therapist, occupational therapist, registered dietitian, privately hired caregivers. Some families want to have caregivers 24/7 and they can get access to those. We have a massage therapist, a music therapist. We have pet therapy through our volunteer program, and we work with a wonderful organization called Heart and Hooves that do miniature horse therapy. We actually bring horses into people's homes, little horses. So the point I'm trying to make there is that we do a lot of stuff to try and make our patients comfortable. We had an ALS patient over Christmas time that wanted to do indoor skydiving, and we made it possible through one of our foundations to take him to do that. I think Keith knows that family. And we have other patients that want to do. We had a family last year, and the father had lung cancer, and he wanted to go back to Idaho for Thanksgiving with the rest of his family. And we were able, through one of the foundations we work with, to get a plane ticket for him and expenses paid for the rest of his family to drive back for a Thanksgiving in Idaho. So we have time and care enough to do all that stuff for our families. My favorite one is a guy, and actually I just did the funeral for this guy yesterday, a guy that wanted to go to the Banana Museum. Has anybody been to the Banana Museum? Did you know there was one? It's at the Salton Sea, just in case you ever want to go. But this guy went to the Banana Museum. That was his wish.
I think we also had a Star Wars
Yes, you did.
movie recently.
Yes, you did. You did. A patient that wanted to go with his son to see the Star Wars movie. That was a good one, too.
That was awesome.
You went on that, didn't you?
I was providing accessible transportation.
Yeah, nice.
And they surprised me with the fact that they had a ticket for me, so that was pretty
Yeah,
pretty
nice.
cool.
That was good. So basically, family and friends are an integral part of patient care when they're on a hospice program, and our families learn that very quickly. And I'm always surprised how quickly they learn what has to be done. They learn how to do, to do tube feeding. They learn how to give medications. They learn what questions to ask about medications. We supply them with all the training, and they have people available 24/7 if they need to call and ask. One of the things that is really obvious to me is it's very empowering to let the family do that, to have them do it. It's those families where they really do connect with the program and make it work that really seem to do the best through the whole process because they know they're helping. They know they're doing everything they possibly can. So I want to quickly go over the 10 top hospice myths. And these are things that I'd like you to be able to take away with you in some way so that if ever anybody has a conversation with you, you can sort of dispel these myths. So hospice is a philosophy, not a place. People sometimes think that hospice is a house or a home or a ward in a hospital or somewhere where you go to stay. And in the early days, that was true. Way back when hospice started in England about 50 years ago, all hospice care was given in dedicated facilities. And then there was a trend when it came to North America that they would have hospice wards in hospitals. The VA currently have a hospice ward, which is really very nice. They do a wonderful job there. But that's the only hospital that has a ward situation. Sharp Memorial have 3 hospice houses, which are houses that I think they have about 5 patients in each, and they are dedicated to hospice care only. But the vast majority of hospice care is given in the home because 90% of people in the U.S. want to die at home. A lot of what we do is bringing patients home to die. And that's one thing that we do that other hospices won't do because it's a risk. I mean, very often we'll take a patient right from the hospital. We sadly had one about 2 weeks ago that died in the ambulance, but we were doing everything we could to get him home. And we'll go out of our way to do that because that's where people want to be. They don't want to be in an institution. And again, home is wherever the patient considers home. So if it's an assisted living facility or a board and care or wherever it is, that hospice care will happen in that place. So any terminal disease qualifies for hospice care, including old age. By the time you get to be old enough, there's usually something that will allow you to be part of the program. You'll have some disease process just as part of aging that will allow you to be part of it. So a lot of the families we deal with, COPD patients, congestive heart failure, diabetes, end-stage renal disease, ALS, of course, and dementia, and obviously cancer. So those are the main categories that we deal with. And in our organization, we deal with only people age 18 and over. Hospice care for children is a whole separate art, and that's pretty well taken care of by Rady Children's Hospital. Elizabeth Hospice, which is another big corporate hospice organization, do have some children in their program as well. So we talked about this. I'm not going to spend a lot of time on it. The statistics show that a lot of patients actually do better when they get onto hospice care. And we see this, I would say, every week. We see one or two people that actually improve when they come home and get appropriate care rather than just having the book thrown at them. So hospice care is not only for the dying patient. The unit of care for us in a hospice program is the entire family. So we don't just care for the patient, we care for the whole infrastructure. And we have programs. We have somebody that does art therapy with the kids, expressive arts therapist that comes in and works with the kids on legacy art projects and that sort of thing. Everybody in the family is important. And the other thing is that our grief services, which is my part of the program, are available to anybody in the community. So if you know of someone, anybody that you think would benefit from a grief group, any hospice program can take them in. As I said earlier, we're the only program that has gender specific. We have men's grief group and women's grief group because men and women grieve very differently. And the groups do better when they're separated. And there's no charge for any of that work. So hospice patients can only receive care for a limited amount of time. We've talked about that. Patient can go on for service for years as long as they qualify. Patients have to give up their own doctor. I touched on that earlier on. They do not have to give up their own doctor, but more often than not, their own doctor would rather sign them over to the medical director on our service because we're specialized in end of life, and most doctors don't have the time to do end of life work properly the way they would want it done. Hospice care is expensive. Hospice services are free, so it doesn't matter. The vast majority of our patients are Medicare patients, and their expenses are covered by Medicare. But at any given time, we have 5 or 6 patients on charity care. We have at least one ALS patient on charity care at the moment, and we pay that ourselves. No two hospices are the same. I've touched on that. I don't need to go through that again. It's absolutely true. So when you're talking with somebody who you think may be hospice appropriate, one of the good reasons to give them 3 is so they can compare the difference between a smaller hospice and a corporate hospice or whatever it is, so that they can see what the differences are. Hospice is for when there's no hope. This is one of the biggest myths and one of the saddest ones. The whole guiding principle when hospice was founded was the principles of hospice are, they say, our job is to help you live life until you die. And we really focus on that. It's not focusing on the dying, it's helping you maximize whatever it is you can do for as long as you can do it. And there's a lot of, surprisingly, there's a lot of laughing, there's a lot of good humor, there's a lot of resolution, there's a lot of emotions that come up and are addressed during the time people are in hospice care that a lot of people wouldn't expect. It's not a morose time at all. Dame Cicely Saunders was the person who actually started the hospice movement. She's a British nurse, and she's a doctor and a writer as well. And I love this quote because I think it's one of the things that embodies most what the hospice spirit is. It says, "You matter because you are you, and you matter at the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." And that's really the very core value of what hospice work is about. And that's all I have. If there's any questions at all, I'm happy to answer them. Keith?
So how does the hospice agency get paid? And is it a lump sum? Is it a per day? Or
That's
just
a great
how does
question.
that?
We get paid per day, per patient, and it's the same matter. It's the same amount. Unless the patient is on general inpatient care. So if the patient goes, we talked about the 4 levels of care. If the patient has to be hospitalized and we're going into a hospital to care for them, we make more money for that level of care, but it's also the level of care that comes under most scrutiny by the Medicare auditors for that very reason.
So there's no incentive on the part of the hospice company with regard to longevity either direction?
No.
It's just per day,
Yeah.
period.
Yeah.
Okay.
And how does a person sign up? How do you get the ball rolling when you realize it's time?
You literally call the agency. You find the names of the agencies you want to speak to. You call them up and say, "I'd like to have someone come out and assess my husband, my mother, my dad, my daughter, whoever it is." And in our organization, we send out. We do one of 2 things. If the patient, for us, if it's a hospital referral, then we send an admissions associate out to the hospital who does all the paperwork with the family. and does just kind of a look over to get an impression whether or not the patient's hospice. Most hospital referrals are very definitely are suitable, otherwise the hospital wouldn't do it, right? Then what happens is within 24 hours a nurse goes out and does the full medical assessment. If it's somebody that just called in sort of on a cold call, we would send a nurse out on the first call, and they would do the assessment right there and determine whether or not the patient was appropriate. And I'd love to tell you that we're turning away patients all the time because they're not appropriate. The sad truth is that the vast majority of people wait far, far, far too long to get hospice involved. And this is really true with ALS patients, really true. There's so much we can do with you whenever you're ready for it.
And that nurse assessment's about 5 hours? Or?
No, 2.
2? Okay.
Yeah, if that.
What if the person is still working? Can they be under hospice care and still be working?
No.
Okay.
No, I have never heard. Well, I'm saying
Okay.
no, and I'm saying it with some hesitation because I've never heard of that happening. I would have to get an answer for you and get back to you on that. But I've never seen that at all.
So once you've stopped working, you're already enrolled in Medicare, and
Yes.
then so you'd be enrolled in Medicare and then make the call to you.
Yes, but private insurances cover hospice too. So for younger patients that say have one of the third-party insurers, Blue Cross or Anthem, any one of those, they will cover it. Kaiser covers it. They'll cover hospice care.
So you don't need to be on Medicare. No.
So you might have covered this at the beginning, but if we start out, so I've got a diagnosis. Mm-hmm. I'm still somewhat ambulatory. Mm-hmm. I'm working, but I'm progressing. Mm-hmm. So at a certain point now, I need a little help in the morning, a little help in the evening, and that burden falls on my family.
Right.
And then as things progress, when do we reach out? Or should we be reaching out? Because I notice you see what happens when we wait too long. So how do you connect with palliative care?
I would say that.
Or what's ahead of that even?
Well, I would say that what you described, the person who's still going out every day but needs help with activities of daily living, morning and night, that person is not somebody who's probably eligible for hospice at that time. I would say with an ALS patient specifically, once you're at the point where you're no longer working and you were spending most of your time at home, still going out in the car and going out and about, but your life was at home, that's when I would make contact at that point.
And if I don't qualify for hospice care?
If you don't qualify for hospice care, you're probably in a situation where you'd be hiring third-party caregivers. And I don't know about other hospice organizations, but we can help you with that. I mean, we have organizations and people that we work with, both independent caregivers that we've worked with in other cases, and then agency caregivers.
Okay.
And those would be self-pay.
And are there hospice resources that start people off in the palliative stage and then transfer them?
Well, no, because...
Or how does that work?
Again, just to go back to palliative, the confusion there is that hospice care is palliative care. If somebody has, say, end-stage kidney disease, and they don't want to have treatment anymore, but they're not considered terminal because they want to go on with dialysis, it's at the discretion of the hospital the hospice as to whether or not they would take them. If a hospice won't take them, then they may very well be able to get palliative care from a home nursing agency. Home nursing agencies, in fact, palliative care under Medicare definition is run by home health, and hospice care is run by hospice. It's two separate sets of laws.
Okay. And do you think we moved over to the term palliative care because it doesn't have the stigma?
Oh, there's no question.
Yeah.
There's no question at all.
It's comfortable over here.
Yes.
Because we don't understand the other.
Right.
But what we think we understand is this 6-month thing.
Yeah.
And I don't want to hear about that, so I don't even want to go there.
Yeah, and that's what I'm hoping. If you take away anything from today, take the 6 months out of your head, because that has nothing to do with other than qualifying you and then making sure you stay qualified. You don't have to worry about that.
So my husband has ALS, and he still can get to work in his wheelchair and his wheelchair-accessible van. He does mostly computer work.
Right.
He's not speaking anymore, or very little.
Right.
but he is able to get to work, and he finds great joy in doing that.
I'm sure he does.
Where I see things is in the morning when he's getting ready for work, and
Right.
he needs. So far, he can transfer into the shower and do that. But for my needs now are, who do I call when I realize that he needs someone to help with bathing in the morning, or to, I leave for work before him, a half an hour before him.
Right.
So I'm a little nervous. Is he okay getting out of the shower? So who do I call? I understand.
Yeah.
My mother had hospice, and this is our daughter, and so she's familiar with father and grandmother.
Right.
And hospice.
Right.
But who do I call now?
Do you have, at the ALS clinic, and I know we have a resource from the clinic here, do you have caseworkers? Do you have a caseworker that works with you, or a social
Yeah.
worker?
I do.
I would ask that person about independent third-party caregiving.
Okay, so ask the social worker
Yes.
at the clinic.
Yes,
Okay.
and they will give you some community resources as to, who to call, which agencies to call.
Thank you.
And who's going to fund that?
You are,
That's private pay.
yeah.
Okay, so they're going to make referrals to agencies or possibly from other ALS families,
Right.
individuals
Right.
who you might be able to hire.
What does that cost? I mean, if it's self-pay, what does it cost if I want someone for
I
an
can-
hour to 2 hours in the morning? Because I'm there in the evening. I get home before him
Right.
at night. But in the morning,
So I'll give you.
how much?
I'm going to talk off the record here, even though I know the entire world is watching. My first choice, if I were in your position, would be to hire somebody who independently, who's maybe somebody through the ALS Society that you know has cared for ALS patients before, so understands the disease and understands the level of care that's needed. And then the reason I'm saying that is that whatever they charge you, that money's going into their pocket. If you go and get an agency worker, you're going to be paying $30 an hour, and your caregiver is going to be making $8. Or and I may be exaggerating, but I'm just saying if you could find.
It's in that 8 to 12 range.
Yeah, if you can find by word of mouth somebody who has done this work before, and it shouldn't be difficult to do, then you're better to get somebody that has experience and that you can get a recommendation for.
So there are 2 agencies locally that will do a 2-hour minimum. Most of them have a 4-hour minimum. So even though you only need an hour and a half in the morning, they're going to charge you for 4 hours just to go there.
Yeah, you don't need that.
So there are 2 agencies who have a 2-hour minimum. Visiting Angels and Maxim. Maxim, M-A-X-I-M. I think there's a magazine by the same name. They're different. Believe me. Yeah, totally different. Yeah. So yeah, it's an issue, and the word of mouth, family to family, on private caregivers, is kind of, you don't want to go on Craigslist.
Right.
No.
Yeah, you get someone in your home that steals everything, or.
I met someone from ALS on the Midway event a year ago. And I'm just, I might make contact with her.
Exactly. So, any other questions? Oh.
If you'd like to give me your email address, I will email you a list of just our private people, the people we have on our private caregivers list.
Yeah, who are familiar with ALS patients.
I'll see. What I'll have to do is there aren't that many of them, so if the list doesn't necessarily say that, but what I would do is you could just call them. It's probably 6 or 7 people.
Oh, sure.
Okay.
You mentioned you had at Interim a number of ALS patients
Yes, we do.
in San Diego County. How many do you typically have, and what are some examples of the kind of services that you most commonly provide to an ALS patient?
That's a very good question. I'm going to answer it very honestly and very openly. And I had to think long and hard last night when I was thinking what I was going to say to you about whether or not we'd go down this path or not, but I want to go down it because I think you probably want to hear it. One of the most common services we're providing for ALS patients now is helping them with the End of Life Options Act. So not every hospice program is willing to participate in the End of Life Options Act. We do. And so that's the most exceptional thing that we do, I would say. Other than that, we do routine care. It depends what stage they come to us. Very often we get people at the very end, or they decline very quickly once they get to us for no particular reason. But for the others, it's just daily care, the way we would do with everyone else. Somebody bathes them and comes in, bathes them, takes care of them, gives the in-home caregiver a chance to get out and do whatever they need to do. And then if there are exceptional things, like I told you, some of the exceptional programs that we have, if it's appropriate to tap into one of our outside resources to make wishes happen and that kind of thing, we do that as well.
So can you page back to that list of all the resources that are available through your program? Because that's, I think, key to the message that people understand by connecting with an agency like yourself. Mm-hmm. That's huge. And you don't see all of this with all the agencies, so shop. And if you choose a hospice provider and things aren't as you expected, fire them.
Yes.
You're not stuck. This isn't a one way. If you don't have a warm and fuzzy, follow your intuition, make the connections, and let that transfer happens in less than 24 hours, right? From one to the next?
Yeah, I should have touched on that maybe. There's three ways you can leave hospice. The one is you can die. The second one is you can revoke, which is what Keith's talking about, and that is that you decide you no longer want to receive hospice care from our organization.
And you don't have to tell why.
No, you don't.
You don't have to have a discussion with them, waste your time and energy explaining. Just pull the trigger.
Yeah, you just say, no, we're not happy.
That's it.
We're going to go with this organization instead. What would happen in that case is that somebody would come over with a revocation document. You just sign saying, yes, that you agree that you revoked, and that's the end of it. We'd be gone. And then the third thing is graduation. And we graduate a fair number of people. So graduation is when someone gets better enough that they no longer need our services. And we do maybe 6, 7 of those a year, and a lot of that is people that come in and we get their medication sorted out and get them healthy and eating again, and they do get well enough to go out. Now, they always come back, maybe 6 months later, maybe a year later, but at least it gives them some time off the program. So the three things then are, obviously death is the primary one, but revocation and graduation are the two other reasons for leaving.
My wife has ALS, and we have some care already coming from your organization.
Nice.
And physical therapist, occupational therapist, and one of my questions is, with ALS specifically, we have this great clinic approach under Dr. Ravitz, for example.
Yes.
With Keith being a key person in coordinating things a lot of times. One of my questions is, how do you interface your independent interim healthcare people with this clinic? They got the same 4 or 5 of those, maybe all of them, at least 4 or 5 of them are the same. So it seems to me there's a little, at least on my part, some confusion about that.
No, we're two separate organizations. We're two separate businesses. You don't have any employees commingled. So you're talking about interim home health care that you're connected with?
Well, things like physical therapists and occupational therapists already have been out and recommended things we need to do in our house.
Right.
Like that.
Right. So that organization is a separate organization from us.
No, I mean, interim healthcare has been out there making suggestions on what to do, and I was wondering, okay, we have the same kind of people that we're interfacing with in Dr. Ravitz's team.
Okay.
And that's what I'm confused.
The question is, why would you want our physical therapist if you already have one?
I use the term, I was getting them as a second opinion.
Okay.
I said, you know what, you're here. This is give me a good second opinion, because I go into the team, they'll be also doing their evaluation. So I was thinking, good, it's good to have more information than not. But that's just what I thought.
Right. Well, usually in that case, the UCSD clinic team has arranged for interim home health to come in, so they know what they're doing there. Now, are they comparing notes and so forth? To some extent, yes. not formally, they're not in the EPIC system, for example, at UCSD, but they're very much aware that activity's been handled. And then when you come back to clinic, there's going to be the follow-up where you share, okay, this is what they recommended. So they're not on the same team, but they're a supplement, a resource that's sent to your house on your behalf. Is that answer?
I thought that interim was transferring all the information to Ravis's team, if you put it a different way. And they're not, based on what you're saying. It seemed a little bit inefficient in a sense, but it's up to us to communicate when we get together with the clinic what the interim caregivers have said.
Yeah.
That's it?
The hub and the wheel is the patient and the patient's family. You're the single point of contact, unfortunately. So it's to your benefit to be your own advocate. And you're also the one keeping track of some of this outside activity and bring it all back in to your primary care provider, your neurologist, or whoever you're meeting with. If you don't tell them, they don't know. Yeah. Any other questions? Okay. Thank you so very much. We appreciate your presentation.
You're welcome.
We do have a VIP from UCSD here in clinical research who's just going to talk to us briefly and plug clinical research and the Center for Disease Control registry. So with that, I'll let our guest introduce herself.
Good afternoon. My name is Danielle Bussey. I work at UCSD with Dr. Ravitz. I'm on his clinical trials team, but I'm going to talk a little bit more about other options for clinical trials, especially if you're maybe further along in the progression of the disease. So as Keith was talking about, there's the ALS registry, which is one of the biggest, I think it's actually the biggest, symposium of data. You register online, and they collect data from different cases of people who have ALS, and the hope is that they'll find more biomarkers, more genes, more things that they can target to eventually maybe cure this disease or come up with a better treatment than the 2 drugs that are already out. So that's a research that anyone who has ALS should definitely register at. Another thing is clinicaltrials.gov. That's the resource you can use to find other clinical trials that are open. You type in the disease. If you go to clinicaltrials.gov, you type in the disease name, and up will pop a list of clinical trials that are open. First thing you want to do before, getting excited about any of the drugs that are out there are scroll down to the exclusion and inclusion criteria. That'll rule out quite a few studies depending on where the patient is at in progression, symptom onset, respiratory function is usually a big thing. For most studies, you have to be above 60%. Also, symptom onset, it's usually around 2 to 3 years, but there's some studies that have as great as 8 years. So it's really just about combing through that list. And if you have a resource, they also can look up clinical trials for you that are going on. We currently at UCSD have 2 clinical trials open. One is a therapeutic study and another is a non-therapeutic study. So the non-therapeutic is CREATE. It's a national symposium of data. So what happens is every 3 months the patient comes in. We'll do respiratory assessments. We'll do, you'll see a neurologist, which will be Dr. Okobu, not Dr. Ravitz. He'll do a couple neuromuscular assessments. We'll draw blood. The first blood draw, we'll send it out for genetic testing. So that's one of the benefits of this study is you get a full result of your genetic testing. So if you have any of the genes or any of the 2 genes that have been marked, you get those results. Genetic testing can often be expensive, so that's a resource you can use. You also have access to more results. Dr. Ravitz and his team, it's usually about every 3 months you're seeing that team. So you get another visit every 3 months, and you can space it out so you're seeing a team about every month and a half. We'll do some cognitive assessments, also just some functional rating, just to see. It's basically just tracking the disease and seeing if we can find any new information that can help. The second trial is called Mallinckrodt. It's a therapeutic drug. It's HP Athcar, so it's a steroid. There is exclusion and inclusion criteria for this study. The point of this drug is to see if it can slow progression. It's not a treatment. Some of the inclusion criteria are a respiratory result of greater than 60%. So that'll be the slow or the forced vital capacity that you might have done in clinic. It's the deep inhalation and then the quick forced out exhalation. Another thing is a 2-year symptom onset, which, can be a problem for a lot of patients, being, a patient could have had, a muscle cramp 6 years ago, but we can't rule that out as that was an ALS. It could have been a muscle cramp, but there's no definitive test saying it was an ALS 6 years ago. Another thing is there can be no continuous needed and required use of the BiPAP device or any respiratory assistive device. Let me think. No positive result of HIV, hepatitis, any of those, and diabetes, since HP Athcar can, you can get raised sugar. It doesn't work well with any diagnosis of diabetes. So those are the 2 trials I'm here to talk about. Do you guys have any questions for me?
Yes. What's the name of the first one?
It's called Create. I can give you, I have some handouts. I'll give you a handout, and then you might have my business card, but I'll give it to you again. Do you have any questions for me? Any other ones? You have one? Okay.
On the trial, the second one, where you mentioned the criteria, if the person is on Radicava already, is that exclusionary?
Yep, Radicava is exclusionary. Here's the catch to that, though. So there's 3 dosings of Radicava. So let's say at the end of those dosings, I think they're now 2 weeks, you have to be off Radicava. So let's say your wife finishes her 3rd dosing. She tapers off for those 2 weeks. If she's still in that eligibility window of the 2 years of symptom onset and her respiratory's fine, blood work comes back fine, she would still be eligible. So we just have to allow that drug to taper off. But the 2 studies cannot be done at the same time.
But the 14 days, after 14 days, then you start another 10-day regimen. So are you saying?
At the end of her full dosing, because I believe Radicava is 3 times. You do go through 3 14-day intervals.
That's news to me.
Oh, okay. Well, either way.
They asked me, and I said, well, I don't know. I assume it's on forever. Radicava.
If, let's say, she gets a side effect, you guys want to go off dosing, as long as, at any point, if she stops Radicava, at the end of that dosing, if she waits 2 weeks, then she's eligible for another trial. A lot of clinical trials, if you're on Radicava, they're not allowing it because they haven't ruled out that those 2 drugs or whatever drug that they're using will not conflict.
Is that second study a double-blind study?
It is a double-blind study. It is. There's a 67% chance that you'll go on the actual drug, and there's a 33% that you'll go on placebo. So it's 2 to 1. So it's a good ratio. Since a lot of studies it's the opposite. But any other questions for me? Okay. Well, I'll be out the back handing out any more information. I can hand you out pamphlets and cards and stuff like that. But thank you.
Thank you very much. So that concludes our February webcast on care services. We'll certainly have contact information for interim home. Your company's Interim Home Hospice. How do we say you?
Interim Healthcare Gift of Hospice.
Interim Home Care Gift of
No,
Hospice.
just Interim Healthcare
Interim Healthcare
Gift of Hospice.
Gift of Hospice. Okay, so you have time to hear that 3 times. And then, of course, we can get you connected with UCSD Clinical Research as well.
Business, I do. I've just
Thank you, and we are done.
This is my